Hello, my name is Wafa. I'm a junior doctor currently working at Nepean Hospital. Today I'm going to be presenting on the topic of renal stones. For the purpose of this presentation, I will use the term renal stones to refer to any deposit that is formed in the kidneys and migrates across the urogenital tract anywhere between the kidney, the ureter, the bladder, and the urethra. However, the correct medical term for this would be urolithiasis. If you want to be specific as to the precise location of the stone, nephrolithiasis refers to a stone inside the kidneys, urethrolithiasis refers to a stone inside the ureters, and cystolithiasis refers to a stone inside the bladder. Renal stones are a common problem in Australia with an incidence of 0.13% per year and a lifetime prevalence of up to 15% in males and 8% in females. 50% of people who experience a renal stone will have another episode in their lifetime. A large part of managing stones is therefore assessing the etiology of the stone and preventing further recurrence, which we will discuss later on in this presentation. The hallmark presentation of renal stones is known as renal colic. This refers to a sudden onset of unilateral colicky pain, with episodes usually lasting between 30 minutes to 1 hour. Renal colic affects the flank area and can radiate into the groin region. This is known as the loin to groin distribution of pain. On examination, there will be renal angle tenderness. This is assessed by placing a hand on the costovertebral angle and lightly punching it with the fist of the other hand. However, sometimes renal colic can present with anterior abdominal pain, and it should always be on the differential list for any acute abdomen presentation. Some patients may present with no pain at all, or they may experience pain initially which later resolves, even without passage of the stone. In order to understand these different presentations, it helps to understand the anatomy of the urogenital tract. The ureter has a diameter of 3 to 4 millimeters. There are 3 sites of constriction which form the most common areas of renal stone obstruction. The first site of constriction is at the pelvic ureteric junction, located between the renal pelvis and the top of the ureter. The second site of constriction is the area where the ureter crosses over the common iliac artery bifurcation as it enters the pelvis. And the third site is at the vesico-ureteric junction as the ureter enters into the bladder wall. Most stones, particularly stones larger than 5 millimeters, become apparent when they pass from the renal pelvis into the ureter and cause a blockage at one of those points I have just mentioned. The same stone can later stop being symptomatic once it enters into the bladder or the urethra. As you can imagine, the bladder has a very wide diameter, and the urethra is also 6 to 9 millimeters in diameter. Hence, stones will usually not be obstructed distal to the ureters. The resolution of pain does not mean that a renal stone has passed, and it is important for patients to confirm passage of the stone with follow-up imaging and by straining their urine. Other associated symptoms of renal stones include macroscopic hematuria and vomiting. If the stone is located in the distal urethra, it can also present with lower urinary tract symptoms including urinary frequency and dysuria, and pain affecting the genital region. If there is a concurrent urinary tract infection, it is important to check the vital signs of the patient for signs of infection or sepsis, including fevers, hypotension, and tachycardia, as this will alter the patient management. If the stone has not yet migrated from the renal pelvis into the ureters, or if a stone is small in size, patients can be asymptomatic, and often the stone is found incidentally on imaging. There are multiple types of stones including calcium, struvite, uric acid and cystine stones, and a few other types which are beyond the scope of this presentation. Multiple risk factors exist for the formation of stones, including lifestyle habits, genetics, medical and surgical background. The most common type of stone is calcium stones, which form about 80% of stones. They can be either calcium oxalate, calcium phosphate, or a mixed compound type of stone. They are radio-opaque, meaning that they show up as an opacity on X-ray imaging. Macroscopically, they have a spiky surface. There are multiple risk factors for developing calcium stones. Number 1. A diet high in oxalate. This is a compound found in many foods, including chocolate, tea, nuts, fruits, and vegetables. Secondly, patients with a medical background of either primary or secondary hyperparathyroidism are predisposed towards forming calcium stones. Therefore, it is important to ask in your history whether the patient has any previous diagnosis of malignancy or parathyroid hyperplasia or vitamin D and calcium deficiencies. Thirdly, vitamin D and calcium supplements can predispose towards stone formation due to increased serum calcium levels. However, it is not currently recommended to advise against supplementation due to other risks, including risk of patients developing osteoporosis, and also the risk of secondary hyperparathyroidism, where low calcium levels in the blood can result in bone demineralization and increased serum calcium levels that can predispose towards further stone formation. Lastly, the patient's surgical background can predispose them towards calcium stones. Patients who have had gastric bypass or an ileal resection have impaired fat absorption. The excessive fat in the gut binds to calcium, hence calcium is not available to bind to oxalate. This results in increased gut absorption of oxalate and predisposes patients towards calcium oxalate stones. Uric acid stones are radiolucent on imaging, meaning that they will not show up on X-ray and would require CT-KUB for confirmation. Macroscopically, they have a smooth surface. The causes of uric acid stone formation include a high purine diet, that is a diet high in red meat intake, and dehydration. Patients with renal failure are also predisposed towards forming these stones due to decreased excretion of uric acid. It is also associated with gout due to common mechanisms which we have already discussed, including high purine diet, dehydration, and renal failure. STRUVITE or magnesium ammonium phosphate stones are radio-opaque on imaging and form staghorn calculi. They are usually formed in the context of urinary tract infection with gram-negative organisms such as Proteus mirabilis and Klebsiella. As you can see in this flow sheet, the gram-negative organism splits urea into ammonia and then ammonium, as well as carbon dioxide. The ammonium combines with phosphate and magnesium to form the calculi. Cystine stones are radiolucent on imaging and macroscopically have a waxy appearance. The cause of cystine stones includes homocystinuria, which is an autosomal recessive genetic disorder of metabolism, where the body is unable to process amino acids properly. The minimum investigations you should perform in the setting of suspected renal stones are highlighted in bold. These include a urine dipstick, urine MCS, EUC, and CT-KUB. A urine dipstick is helpful in confirming suspicion of renal stones and also to detect if there is any urinary tract infection, as this will change the patient management. Hematuria is present in 85% of renal stones. A high white blood cell count and nitrites will suggest a urinary tract infection. Urine MCS is useful in confirming this, and the growth of culture and sensitivities can be used to guide antibiotic choice. EUCs can be useful for monitoring renal function. A mild pre-renal AKI can be found in patients with renal stones. This is usually due to dehydration from vomiting or reduced oral intake that will reverse with intravenous fluids. Renal failure from obstruction is highly unlikely, as the contralateral kidney will usually compensate for any temporary decrease in function of the affected kidney. The only exception to this is if there is a bilateral obstruction or in patients who only have one kidney. Other blood tests to consider to assess the etiology of stones include serum calcium, uric acid, and parathyroid levels. If the patient is able to strain their stone, stone analysis can be useful to assess the etiology and guide further prevention of stones. CT-KUB is the gold standard imaging of choice for renal stones, with 99% of stones being radiodense. It also has other benefits, including detecting signs of obstruction, including hydronephrosis and perinephric stranding. So in this CT scan, you can see there is a radiodense area located in the middle segment of the left ureter, indicating a stone. This slide is a sagittal view of the same CT scan from the previous slide. Again, you can see there is a radiodense area located in the left ureter. X-ray KUB should not be used routinely as a first-line imaging for stones. However, it does have some advantages. It can identify large radio-opaque stones, including calcium and struvite stones, and it also has lower radiation exposure compared to CT. It can be useful for follow-up in patients whose stones have already been detected on X-ray, meaning that their radiation exposure is decreased. The disadvantage of X-ray KUB is it cannot detect smaller stones or radiolucent stones, and it cannot assess for signs of obstruction or hydronephrosis. So in this image you can see that there are two radio-opaque stones located in the middle segment and the distal segment of the ureter. This X-ray image demonstrates a left staghorn calculi, which is characteristic of struvite stones. So renal ultrasound is another type of imaging that should not be used as a first line, but it can be useful in certain population groups. For example, in pregnant women where we want to avoid radiation exposure. It can also be useful in terms of following up patients to ensure resolution of obstruction and hydronephrosis. So in this image you can see there is a hyperechoic stone with posterior acoustic shadowing, which is quite similar to how you would find a gallstone in the gallbladder. So this renal ultrasound image demonstrates hydronephrosis, which is a collection of urine within the renal pelvis. Hydronephrosis indicates that there is obstruction to urine drainage from the kidneys. Since urine is a liquid, it does not generate any echoes on ultrasound and presents as a black area. And you can see that on this image. The general management of renal stones includes analgesia for all patients, as well as optionally IV fluids, antibiotics, and surgery. The indications for active management, that is surgical intervention, include stones which are larger than 5 millimeters as they are unlikely to pass, patients who are experiencing ongoing pain despite analgesia, patients who have renal failure secondary to obstruction, patients who have a urinary tract infection, as this can result in life-threatening sepsis, patients who have failed conservative management, which is usually 4 weeks from the onset of stones, and patients in certain occupational groups such as airline pilots. Conservative management involves providing patients with analgesia and waiting for a spontaneous passage of the stone. NSAIDs have been demonstrated to be just as effective as opioids in managing pain in renal stones. Usually they can be given through a perirectal, intravenous, or intramuscular route, especially in patients who have nausea and vomiting and cannot tolerate oral intake. The perirectal route is usually the choice for providing NSAIDs, as it does not require a cannula or a needle for patients to administer medications, and they can be discharged home. Regardless of the route, the same contraindications apply as for oral NSAIDs, and NSAIDs should be used cautiously in patients with renal failure and peptic ulcer disease. Paracetamol can also be used for analgesia. The alpha blocker tamsulosin assists in expulsion of the stone and reducing pain from urethral spasms. They are contraindicated in patients with end-stage liver or renal failure and patients with orthostatic hypotension. If the pain is not controlled by the above, then opioids can also be added. Patients should strain their urine whenever they urinate using a tea strainer. If the stone is found, then it should be provided to their local GP for stone analysis. A CTKUB should also be done to confirm passage of a stone. If there is no evidence of stone passage within 4 weeks of onset of the renal stone, then conservative management would be considered to have failed, and the patient would have to see a urologist for consideration of surgical intervention. Active management involves providing IV fluids for patients who are dehydrated, antibiotics to prevent development of urosepsis, and surgical interventions. There are a few surgical interventions available for renal stones. The first one is ureteroscopy with laser lithotripsy and stent insertion. This involves passage of a telescope past the urethra up into the ureter or the kidney. Laser is used to fragment the stone, and this is extracted via a basket. A stent is then inserted and kept in for 1 to 2 weeks in order to maintain a passageway between the kidney and the urethra, and it is later removed in an outpatient procedure. The advantage of this procedure is that it has a high success rate and you are able to retrieve the stone for biochemical analysis. It is also widely available. The disadvantages are that it requires a second procedure to remove the stent, and patients often complain of secondary stent symptoms, including lower urinary tract irritation, hematuria frequency, urgency. The second type of surgical intervention is shockwave lithotripsy. This can be used for stones which are smaller in size. It involves the use of sonic waves via X-ray or ultrasound guided imaging to shatter the stones. They are then passed in the urine, and it has a success rate of about 75%. It is ideal for stones which are still in the kidney. The advantages is that it does not require a stent and is minimally invasive. The disadvantages are that there are certain risks, including obstruction from stone fragments and perinephric hematoma, and it is not widely available. The third type of surgical intervention is percutaneous nephrolithotomy. It can be useful for larger stones, including staghorn calculi. It involves an incision through the back of the patient and into the kidney. Stones are removed from a telescope. It usually requires hospitalization for 2 or 3 nights after the procedure. The advantages is that it provides good access to larger stones and it has a high rate of stone clearance. There are certain risks associated with the procedure, including damage to the kidneys and risk of developing pneumothorax. Another disadvantage is that it cannot access stones which are in the ureter. It has a higher morbidity rate as well. The last type of surgery, which is rarely used, is open surgery. It can be useful in certain situations such as very large stones, abnormal kidney anatomy, or in procedures that require correcting of other abnormalities at the same time as removal of the stone. An important part of managing stones is preventing future reoccurrence, as up to 50% of patients re-experience stones in their lifetime. General management includes encouraging oral hydration to avoid stone precipitation, to prevent further development of calcium stones. A diet low in oxalate and salt can assist, as well as treating any hyperparathyroid conditions and sometimes use of thiazide diuretics. To prevent formation of struvite stones, patients who have recurrent urinary tract infections can take prophylactic antibiotics or in general treat urinary tract infections early. Patients who are prone to uric acid stones can commence allopurinol, which is the same medication to lower uric acid levels in gout. Uric acid stone formers also tend to have more acidic urine, so alkalinizing the urine with use of agents such as potassium citrate and sodium bicarbonate can prevent stone formation. In patients who have homocystinuria, penicillamine is a chelating agent which can help dissolve cystine stones by forming a complex with it. And this can help prevent stones and also dissolve existing stones. There are few complications of renal stones, as we have discussed before: the possibility of infection and developing sepsis, as well as renal failure in patients with a single functioning kidney. Stones can also result in post-obstructive diuresis, where there is a high urine output of more than 200 mL per hour after removal of the stones. This can be managed by replacing with IV fluids and electrolytes. The other main complication is recurrent stone formation, which can be prevented as outlined in the previous slide. And recurrent stone formers also have an increased risk of developing bladder cancer. So this is the end of my presentation. I hope you learned something, and you can email me at my address if you want to ask any questions. Thank you.